Hi all, I'm Malavika, and in this video I'll be explaining about ACE inhibitors or angiotensin converting enzyme inhibitors. Examples of ACE inhibitors include captopril, enalapril, lisinopril, ramipril, fosinopril, quinapril, and so on. So all these drugs end with the word pril. Coming to the classification of antihypertensive drugs, antihypertensives can be broadly classified into 5 types. We have diuretics, RAS inhibitors, vasodilators, sympathetic inhibitors, and calcium channel blockers. ACE inhibitors come under the RAS inhibitors or renin-angiotensin-aldosterone system inhibitors. Now let's take a look at the mechanism of action of ACE inhibitors. ACE inhibitors, as the name suggests, inhibits the enzyme ACE or angiotensin converting enzyme, which converts angiotensin 1 to angiotensin 2. Now angiotensin 2 is normally responsible for vasoconstriction. So when ACE inhibitors are taken, angiotensin 2 levels will fall and this will lead to arteriolar dilation. This will decrease the peripheral vascular resistance. Now, angiotensin 2 is responsible for the production of aldosterone. So, when angiotensin 2 decreases, aldosterone will also decrease. This will lead to decrease in sodium and water retention. That is, more sodium and water will be lost from the body. Now, when angiotensin 2 falls, sympathetic activity will also be decreased. All these 3 factors contribute to hypotension or fall in BP. Angiotensin converting enzyme is also responsible for the degradation of bradykinin into inactive peptides. So when ACE inhibitors are taken, angiotensin converting enzyme gets inhibited and bradykinin will increase. Now bradykinin is a potent vasodilator and it is also known for stimulating the synthesis of vasodilating prostaglandins. These 2 actions will further lead to decrease in BP. Coming to the pharmacokinetics of ACE inhibitors. They are usually given orally. Most of them are prodrugs, that is, they are inactive forms of the drug which are converted into their active forms in the liver. So, metabolism happens in the liver. Example, enalapril, which is a prodrug, is converted into its active form enalaprilat. Enalaprilat is given intravenously in hypertensive emergency. Now, exceptions for this statement include captopril and lisinopril. They are not prodrugs. Food reduces the absorption of captopril, so it is taken 1 hour before meals. It poorly crosses the blood-brain barrier. Excretion is in the urine. Next, we have the therapeutic uses of ACE inhibitors. First is hypertension. ACE inhibitors are the first-line drugs for hypertension. They do not cause electrolyte disturbances, hyperuricemia, dyslipidemia, sexual dysfunction, or rebound hypertension on stopping therapy. They are most suitable for use in hypertensive patients who are less than 55 years of age. They are used in hypertensive patients with diabetes mellitus because they prevent or delay renal complications. They are also used in patients with nephropathy, congestive cardiac failure, left ventricular hypertrophy, and peripheral vascular disease. Another use is acute MI. ACE inhibitors are started within 24 hours. They decrease the chances of reinfarction. Another use is congestive cardiac failure and left ventricular dysfunction. ACE inhibitors are also used in diabetic nephropathy. Reasons: they dilate the efferent arteriole in the kidneys and this will decrease the intraglomerular pressure. They also inhibit angiotensin-mediated mesangial cell growth, which has a renal protective action. It also decreases microalbuminuria. Another use is scleroderma renal crisis. Now we have the contraindications of ACE inhibitors. First is pregnancy, because ACE inhibitors can cause teratogenicity. Then we have bilateral renal artery stenosis. Now, in case of bilateral renal artery stenosis, the renal perfusion pressure will be low. Now, normally when the renal perfusion pressure falls, angiotensin II will be responsible for the constriction of efferent arteriole, and this will increase the intraglomerular pressure and GFR will be maintained. Now, when ACE inhibitors are taken, angiotensin II will decrease. So, this whole mechanism is blocked and this can precipitate acute renal failure. Adverse effects of ACE inhibitors include dry cough, angioedema, proteinuria, teratogenicity, hypertension, neutropenia, rashes, itching, loss of taste sensation, and hyperkalemia. Finally, we have the drug interactions. ACE inhibitors plus potassium sparing diuretics can cause dangerous hyperkalemia because both drugs have hyperkalemic effect. ACE inhibitors plus lithium can lead to lithium toxicity. ACE inhibitors plus NSAIDs. NSAIDs are known for inhibiting prostaglandin synthesis. This will increase sodium and water retention in the body, and this will decrease the antihypertensive effect of ACE inhibitors. So all these three interactions are harmful. We have one beneficial effect also, which is with thiazide diuretics. When ACE inhibitors are taken with thiazide diuretics, the antihypertensive effect of ACE inhibitors is increased because thiazide is also an antihypertensive drug. Another beneficial effect of this combination is that ACE inhibitors are responsible for hyperkalemic effect and thiazides have a hypokalemic effect. So, serum potassium levels are maintained. So that's all about ACE inhibitors. Thank you for watching.